Good afternoon and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative. Thank you for taking the time to join us for part 2 of Detecting and Managing Suicide Risk in Pediatric Primary Care Settings, presented by Dr. Lisa Horowitz with the National Institute of Mental Health. My name is Kathy Dixon and I'll be facilitating the session today. Before I introduce Dr. Horowitz, I'll cover some brief housekeeping announcements. The webinar will be recorded and available for viewing after the session. I'll send the link to the recording in the follow-up email after the webinar. We have time for Q&A following the presentation, so please feel free to type your question into the question box. It's located in the GoToWebinar control panel, and we'll cover as many questions as time allows. Instructions on how to claim continuing education credit is located in the handout section of the GoToWebinar control panel. It's available to download, or you'll receive it in the follow-up email after the webinar. So without further delay, it's my pleasure to introduce Dr. Lisa Horowitz. Dr. Horowitz is a pediatric psychologist and a senior associate scientist at the National Institute of Mental Health at NIH. Dr. Horowitz received her doctorate in clinical psychology from George Washington University, completed a pediatric health service research fellowship at Harvard Medical School, and obtained a master's in public health at the Harvard School of Public Health. The major focus of Dr. Horowitz's research has been in the area of suicide prevention in the medical setting. She is lead PI on 5 NIMH suicide prevention protocols that involve validating and implementing tools for clinicians, such as the Ask Suicide screening questions, the ASQ. She is also one of the co-authors of the Blueprint for Youth Suicide Prevention, released by the American Academy of Pediatrics this past March. Dr. Horowitz is collaborating with hospitals and outpatient clinics around the country, assisting with implementation of suicide risk screening and management of patients who screen positive using the ASQ toolkit and clinical pathways. So welcome, Dr. Horowitz, and I'll turn it over to you.
Thank you so much. It's such a pleasure to be here for part 2. I enjoyed part 1 and all your questions, so I look forward to that part at the end. Okay, so you can hear me okay and see my screen? So again, yes, because that's a picture of NIH in Bethesda, Maryland, where I am, and I have no financial conflicts to disclose. So I didn't know how many of you were involved in part 1, so I just thought I would very briefly today, before we get to this, just go over a brief epi of suicide. But our main objective today is to train to conduct this critical middle step of the 3-tiered pathway called the Brief Suicide Safety Assessment that you do when someone screens positive for suicide risk. And then we're going to talk about how the BSSA fits into the 3-tiered pathway that I spoke about in part 1. And then again, you know, one thing people worry about when they implement suicide prevention in their practice is, what if I can't bridge this person who needs help to mental health? What are some quick interventions you can do in your office to make this feasible? So we'll discuss that as well. So just as a brief summary, youth suicide, depending on the age, it's either the second or third leading cause of death. It was the second leading cause of death in 2019 for 10 to 24-year-olds, but homicide has edged out suicide in this age group in 2020. When we look at all the reasons why kids die, or all youth deaths, and you know, kids aren't supposed to die, they're supposed to grow up and live long, healthy lives. 17% of those deaths are from something that's potentially preventable, which is suicide. So 17% is just, you know, way too high a number. And if we look over time, we just see the suicide rate creeps up and up. We had a slight dip in 2019 and then an exacerbation in 2020, most likely from the pandemic. So there are disparities in the suicide risk, and this is really important that, and I'm going to show you some of them, but it doesn't reflect, it doesn't stem from the identities on their own. It's more systemic inequities and barriers to healthcare. So If we look over the lifespan, this black line is American Indians, Alaskan Natives. They have the highest rate of suicide than any other racial or ethnic group. And then these are suicide attempts. This dotted blue line that is increasing is Black youth. Black youth now have the steepest increase in suicide risk, so much so that the Congressional Black Caucus put out a Ring the Alarm report calling for more intervention with Black youth and suicide. So screening, we hope, really can bring health equity, or a piece of it, and not only for people of color, but for LGBTQ+ individuals, youth with neurodevelopmental disorders like autism, kids in the child welfare system, juvenile detention centers, and people living in rural areas that don't have access to mental health care. Screening can really help identify underserved, understudied individuals and then link them to care. So I really want to drive home this point about screening versus assessment, because people often conflate these two ideas and they're very different. Screening is a very rapid way to identify someone who needs further assessment. The assessment is a much more comprehensive evaluation. It confirms the risk, it guides next steps. So in part 1, we did training on screening. Part 2, we're going to do training on assessment. So very briefly, recap of the screening. We were training on using the ask. In the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And have you ever tried to kill yourself? If the patient answers yes to any one of these questions, we ask a 5th acuity. If they say no, which the majority of patients will, we don't ask the 5th question. The 5th question is, are you having thoughts of killing yourself right now? And that helps us determine if this is an acute positive or a non-acute positive. So majority of screenings are going to look like this. They're going to be 20 seconds and they're going to be a negative. So maybe depending on who you're screening, where you are, could be about 90–95% of your patients are going to be negative. When they're positive, you ask that 5th question, and if it's a no on the 5th question, that's a non-acute positive. For patients presenting with medical chief complaints, 99.5% of your positives are going to be non-acute positive, and then 0.5% are going to be an acute positive. So that the acute positive is the emergency. The non-acute positive is not an emergency. It's important that you know that they're at risk for suicide, but it's not sent to the emergency room or put on full safety precautions. So we can talk more about that at the end, but anyone who screens positive requires a brief suicide safety assessment. So what happens when a patient screens positive? So first, here's what should not happen. And I think this is really important because this is the fastest thing that shuts down a screening program. We can't treat everyone who has a thought about suicide like they're an emergency. Again, important to know, but it's often not an emergency. It's the time to listen, to have the conversation, and figure out how to help them, right? So too often, a patient will talk about suicide and then they get put in a paper gown, all their clothes are taken away, their belongings, they're given a very costly one-to-one sitter, or they're sent to the emergency department, and this happens. And what we're hoping to do with this 3-tiered pathway that I'm going to show you is avoid these situations. Now, every now and then, this situation, it will happen. It will be a true emergency, and then you should be prepared, and your practice should be prepared. But the majority of time, it will not be this. So this is the pathway that we believe will make screening feasible. And also make the patient not feel punished for telling you, right? Because when they get put in a paper gown and they're treated like, you know, a security guard is put out, it's just, it feels punitive. And so, and it's very costly resource-wise. So we want to make this feasible. So last time we talked about the brief screen. We're going to do the 2nd tier today, which is actually the most important part of this pathway, is the brief suicide safety assessment. And it's the most important part because it determines next steps. What does your patient need now? Do they need a full mental health evaluation? Can they get that outpatient, or no further action is necessary at this time? So that's what we're going to look for. So the first thing you need to determine is they were screened, and it was positive, was it acute or non-acute? Because these two situations are very different, right? So let's do the rarer one, is the acute positive. Now this means that you picked up somebody who's at imminent risk by screening. And so you do need standard of care safety procedures. What do you do when you're worried that someone's going to kill themselves? So when you're in an office, an outpatient office, you don't leave the patient alone. You make sure that someone is with them at all times. You can remove harmful items from the room, and the patient needs an urgent mental health evaluation. This means sending to an emergency department if you have to, and the patient shouldn't be left alone. So this is the acute positive. The more common presentation is the non-acute positive. So what this means is risk was detected, but it's not imminent, and it's not an emergency, but it's important, right? So the patient needs what's called a brief suicide safety assessment from someone who is trained to do that. Patient can be left alone, and the patient is asked to stay. And this is something that I've actually spoken in person with to the Joint Commission to make sure we're all on the same page. But if the parent doesn't want to wait around for the brief suicide safety assessment, or the patient is over 18 and refuses to stay, it's treated as anything else against medical advice. So it'd be as if you found something else, like maybe the patient had a skyrocketed blood pressure and you wanted them to stay because you wanted to complete another assessment, and they said no. You would have them sign out whatever your version is of against medical advice. Now this is the pathway. So these are those 3 tiers, but fleshed out. And I don't expect you to read this. I'm just showing you that if you did want more details, it is fleshed out of how to implement this in your office. But it boils down to these 3 pieces. And what I've learned from observing and consulting on implementations is that it should be very flexible. There is nothing rigid about what I just showed you, that other pathway. That what I feel the most confident in are these 3 tiers. How you do them matters where you are, your setting, your milieu, the culture of your setting. And so there's a million ways you can do it, but these 3 tiers are really important to stick to. So today we're going to be talking about the brief suicide safety assessment. Now what's important to remember about this is not an hour, this is not 45 minutes, this is supposed to be 10 or 15 minutes. And it's not supposed to be the full mental health evaluation. This is the middle step that helps you decide what happens next with the patient. So who can do a brief suicide safety assessment? Now, when we went over the screening, we said screening can be done by anybody who's trained. The screening was developed for nurses, for medical technicians, for medical assistants. The brief suicide safety assessment should be done by a clinician. It ideally would be a social worker or a mental health clinician, but most places that we train don't have social workers or mental health clinicians available to do this part. So it could be a nurse practitioner, it could be a physician's assistant, it could be a physician, or someone else that is trained to do a brief suicide safety assessment. So these are 2 different tools that are available to do a brief suicide safety assessment. There's the Columbia Suicide Severity Rating Scale on the right, and then we developed something called the Ask Brief Suicide Safety Assessment on the left. If you use the Columbia, you have to pair it with something else because if you're under Joint Commission regulations, it has to be risk and protective factors. And that was one of the reasons why we made the Ask Brief Suicide Safety Assessment. So I'm going to train you how today, because there's a lot of different ways to do this, but because my group was part of developing the Ask BSSA, I'm going to train you on that today. So this is what the Ask Brief Suicide Safety Assessment looks like. This is for outpatient. In our toolkit, in our Ask toolkit, we have different versions of this, different versions for youth and adults, different versions for different settings. This is the outpatient one. Now, you might look at this and say, wait a minute, how am I going to do that in 10 or 15 minutes? And the purpose of this is a guide. You don't have to do every single piece of this. And as soon as you get to your disposition, which I'm going to show you, you can stop. So the first thing you do is, so this patient has just been screened. And so you're going to come in and you're going to say, I'm here to follow up on your responses to the suicide risk screening questions. These are hard things to talk about. Thank you for telling us. I need to ask you a few more questions. And then this is your guide. And it's going to prompt you to talk about the frequency of suicidal thoughts, right? And it gives you some idea of how to do that. And you might repeat some of the questions. But you want to determine how often is this happening, because more is more worrisome than less. So then it's going to say, and it's important to ask again, are you having thoughts of killing yourself right now, even if they said no to the screen? Because sometimes kids especially will answer these things differently, and you just want to know, is this something that's an emergency? Then we have ways of asking about the suicide plan. So do you have a plan to kill yourself? And then what is that plan? And a lot of times when some children or youth will say, I don't have a plan, no, I don't have one. And sometimes I push them a little on this, because this is a good indicator of how much they've thought about it. So even if they say no, I said, well, if you were going to kill yourself, how would you do it? And there'll be a lot of kids that will still say, I don't know, I haven't really thought it through. But then there'll be the kid who has a very detailed plan about how to do this. And people who have very detailed plans are more worrisome. So that's where your antenna starts to go up. You'll ask about past behavior, right? So what the number one risk factor for suicide, the most potent one, is past behavior. Anyone who has attempted suicide in the past is at more risk to attempt in the future. So you will ask, and you can ask this, it's important to use direct language, but you can also ask, have you ever tried to hurt yourself? Have you ever tried to kill yourself? So hurting and killing, a lot of kids think about in different ways. So it's important not to just use hurt. It's important to use the word kill. Have you, or if you start with hurt and they said they did something, then you might say, was it an attempt to kill yourself? Did you want to die? And then you ask about it. Did you want to die? Did you receive medical or psychiatric treatment from it? So all this is giving you information. Now, let's say you started your brief suicide safety assessment and you find out they're thinking about this every single day. They have a detailed plan and they tried to do it before. You don't even need to keep going, right? If you're already knowing that this is pretty urgent, then you can stop, because this is not to be the thorough evaluation. This is to get to next steps. But lots of times it's not that cut and dry. So there's symptoms that we worry about: depression, anxiety, impulsivity, hopelessness, and the list goes down. And we provide some prompts about how you can ask about this. And then it's important to ask about the protective factors, the social supports. Do they have a support network? Who is their trusted adult? Do they have one? And what's happening at school? Do they know people who have died by suicide? And then often we ask kids, people remember to ask them about why they want to die, but we forget to ask them why they want to live. So reasons for living is a really important indicator. Do they have reasons for living? Some youth will tell you, like, I would never do that because I would never want to leave my brothers and sisters. I wouldn't do that to my parents. Like you can just hear a different risk factor in their voice or a different indicator when they talk about their reasons for living. Sorry, my light goes automatically off if I don't move. And then there's a way to bring the parent. Now, ideally, this is done alone, and hopefully the parent will give you space to do it. But when it's time to bring the parent in, you know, it's important that the parent doesn't feel blamed. And, you know, if you can think about it, the number one life stressor is losing a child. But losing a child who kills themselves is just, you know, it's an impossible thought for many. And for parents, it's very, very scary, as you know, I'm sure you know. But it's important to not have them not feel blamed. So one of the ways we do that is, instead of saying, you know, did you know about this, which can sound like they should have known, we say, your child said, you know, they wish they were dead. Is this something that they shared with you? Because if you ask it like that, then it's a question, like, is this something they shared with you? Because maybe it's not. And it's important to know that most kids who think about suicide don't share it with their parents. And it's not, and their parents don't know about, there's some studies showing that the majority of suicide attempters go unrecognized by their parents. And it's not because they're bad parents or they're not paying attention. It's because kids keep these kinds of things to themselves. So now you're partnering with the parent. And then it's important to ask them, are you, you know, now knowing what you know about your child, are you comfortable keeping them safe at home? And then, is there anything you would like to tell me in private? Those are important pieces to ask, because maybe there's a family history of suicide that the parent doesn't want to talk about in front of the child. And then you can make a safety plan with the patient, and if possible, include the parent. And this gives you some guides. We're going to talk a little bit more about that, so I'm not going to spend too much time here. But the whole purpose of this brief suicide safety assessment is to get to the disposition. So think of this middle step is, I'm going to operationalize what I do next. And as soon as I have what I'm going to do next in my mind, I don't have to continue with this brief suicide safety assessment. So one, maybe it is an emergency. Maybe it was a false negative on the screen, and this is an emergency and the patient's at imminent risk. Or maybe further evaluation of risk is necessary. So that's going to be the most likely outcome. Or a patient could benefit from a mental health evaluation, but it's not urgent. It doesn't have to happen in the next few days. Or no further interventions necessary at this time. And then anybody who screens positive and you do this BSSA, it's really good to follow up with them at the next appointment. And then you can provide resources, and we're going to talk more about this too. Okay, so just to make sure it's clear, the purpose of the BSSA is to figure out which one of these boxes the patient falls into. Is it imminent risk? And I think, you know, imminent risk and low risk are much easier than this middle category, which is I'm on the fence, but I think it's not an emergency, and you know, I'm worried about them, but they need a further evaluation as soon as possible. So this is just an example of the different versions available in the toolkit. Okay, so now I want to talk about an example of a yes to past behavior, because this is what happens a lot. Patient says no, 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 and you ask about past behavior, they say yes, and it's a non-acute positive. So we did a study, and about a third to a half of patients who screen positive look like this. And so there's bad news and good news of that. The bad news is there's a lot of kids out there that try to kill themselves. The good news is that as a screener, this might not be something that becomes the business of the day. And I'm putting that in quotes because, you know, maybe they're there to see you for, you know, their asthma, and you picked up a positive screen, but it's something that's already being dealt with and something the parent knows about. So in the pathway, we have this provision because we see this happen a lot. So if the patient answers yes to that fourth behavior question, The problem is that from now on, they're going to be positive every single time they're in your office because they have past behavior. So we recommend inserting the language since last visit. So if it's October, if I saw this patient in April and I have the ability to see what happened last time and they were a positive on the behavior question, I might say to them, so you were here in April, since April, have you tried to kill yourself? And then if they say no, and that was the only positive or potential positive, then I'll ask, was the attempt more than a year ago? Or these are things to consider. Has the patient received or currently receiving mental health care? Is the parent aware of it? And is the suicidal behavior not a concern? Because if all these are yes, then I can consider the low risk action for choice. I don't have to do this every single time because they once tried to kill themselves. It's good to know that they're at greater risk. But if everything else seems okay, then I don't have to put them through my pathway every single time. Okay, so now there's a pediatrician who is a suicide prevention champion named Dr. Leah Gugino from Michigan. And we have done this before in CEU courses and things like that. And so we made a video, she made it, and with the help of my research assistant, Nathan. And so this is going to be a mock brief suicide safety assessment. So this is Nick, 17-year-old at a well visit, right? And this is what his ask looked like. He said yes to the first question, but no to everything else. So this is Dr. Gugino doing a brief suicide safety assessment. And remember, so he screened non-acute positive, right? So this is just an example of what it might look like. I'll also tell you that in her practice, she also gives PHQ-9s. So she's going to bring in, he screened positive on the 9th item and also, as you saw, on the ask.
Hey, Nick, how are you?
Too bad. How are you?
I'm good. I'm really glad to see you. It's been a long time. So things are going okay? What do you think?
They're okay.
Okay.
Yeah. Life is okay so far.
Okay, and I see you're coming in. You need a sports physical for basketball. So we want to take care of that. And I know this is your senior year, right?
Yeah.
And so you're probably thinking about what you're going to do after high school. That's always a lot on people's minds.
Yep. Love to keep playing basketball for college. So.
Yeah. Okay. Have you had some offers? Are you doing some applications?
Starting applications, so it's a little stressful right now.
Yeah, I can imagine. Well, hey, before we get started, we always have lots of questions to go through. And I had you fill out some forms, which, I give to all of our kids when we do this. And there were a couple of things I just wanted to ask you about. I noticed on we call it the PHQ, it's the depression screen. And I noticed that there were some things that you filled out, and that I'm kind of wondering if you're not feeling real good. It looks like you're having some trouble sleeping. Can you tell me about?
Yeah, that's right. Yeah, just for the past couple of weeks, it's been really difficult for me to fall asleep. I, kind of lay in bed for a while. Really hard for me to fall asleep, and then, I'm kind of restless at night sometimes. And then I think it's really tired throughout the day. Kind of low energy. It's, kind of affecting my basketball. It's kind of, hard to keep up energy for that right now.
Yeah, but what time do you go to bed at night? I mean, what time are you actually able to fall asleep?
Yeah, I think it takes a while sometimes, maybe 40 minutes to fall asleep. I'm just kind of laying there, kind of just restless, turning over.
Yeah, so are you, anything in particular you think's going on as far as why it's been so hard to fall asleep?
Recently my boyfriend and I broke up. So that's been pretty hard. Kind of out of the blue, he ended it. Wasn't expecting it. So that's been kind of keeping me up at night right now, I think.
You guys have been together for a long time, right?
Yeah, over a year. So
Yeah, that's a long time. Well, I'm sorry about that. I bet that's been really hard.
thank you. Yeah, it has.
The other thing I was noticing was one of the questions you said sometimes you thought you might be better off dead. And then on the other screen, you actually said you had thoughts about that, about wanting to be dead. Can you tell me a little bit more about that?
Yeah, I don't know. I'm just like, after my boyfriend and I broke up, I don't know, I'm just kind of, down on myself. I just, kind of, in pain from that. And I just, just kind of wish it would go away.
Yeah. Yeah, I think a lot of people in a similar situation might have thoughts like that. How often are you thinking about that you might rather be dead?
Not too often. It's just kind of late at night when I'm, having trouble falling asleep. That's really when it kind of pops up. I don't like those thoughts, but they kind of come across.
Yeah, I would think that would be kind of disturbing. I mean, have you ever thought about, if you were going to kill yourself, how you would do that?
No, never.
Have you ever made an attempt or ever tried to kill yourself?
No.
Okay. How likely do you think that might be to happen?
They're pretty low. Like I said, I don't like having these thoughts, but I would say very low.
Yeah. And do you think at your house, I mean, would it be easy to get into things like, medications, pills, anything like that?
Yeah, I mean, my mom does have some pills in her cabinet I could probably get a hold of, but like I said, I don't have any plans for that.
Okay. Well, I'm glad to hear that. I know those thoughts sound like they're really disturbing. I did want to ask too, just as a safety question, are there any guns or firearms in your house?
I think my dad has a firearm, like a handgun, but I'm not sure, and I don't know if he does where he keeps it, but I think he does.
Okay. Well, I think we can go ahead and do a couple other questions that I have for you, and then at the end of our visit, what I'd like to do is talk with your mom a little bit about some of these thoughts that you're having and how we can support you, because what I've heard you saying, and you'll have to tell me if I don't have this quite right, is there are some times that you've been really thinking hard about, breaking up with your boyfriend to the point that sometimes that you just wish you weren't alive, that you haven't had a plan or have actually never tried to kill yourself, but the thoughts are there and you don't like the thoughts, right? But there are a couple of things in your house, and I'm wondering, right now, I think there are some safety things that we can talk about with your mom, and for sure I want to talk with her about removing the gun from your home. I know you're not thinking about that, but I just like to make sure that kids are safe and that homes are safe. And then there might be some things we could talk about too, just to help you get through the breakup. And I know the stress of college, sometimes talking to a therapist can be helpful. What do you think about that?
That sounds good to me. Yeah.
Okay. Well, I've got a couple other questions to ask you, and then we'll get to the exam, and then we'll have your mom come in if that sounds okay.
Yeah, that sounds good to me.
And was there anything else? I know this is kind of hard stuff to talk about, but I'm really glad that you shared that with me.
Yeah, no, thank you.
Okay. All right. Well, let's go ahead and we'll move on to the next part of this, okay?
Okay.
Okay. So that is a really good example of a really good brief suicide safety assessment. And she determined that, he's thinking about it. It was dystonic to him. He didn't like having the thoughts, which isn't always the case. But she determined he was probably needed some mental help and to tell his parent. And so we'll talk about this. One, what happens if he had said, hey, I don't want you to tell my mother. No, I don't want to do that. So I get that question a lot, and it's important, you know, there's different laws in different states, but we're all mandated reporters. And so suicide is not covered by confidentiality. But what you can do with the child is, you know, I have like a, Dr. Ted Abernathy was a seasoned pediatrician, suicide prevention champion that we started our work with. And he used to just look at the kid and say, listen, I don't want to see you dead. And so I got to tell your parent because I want you to be safe. And then what you could do also is give the person a choice. So we're going to need to tell your parent in order to keep you safe. Would you like to be the one who tells them? Would you like me? Would you want to be in here? Do you want me to do it alone? What is the best way for you that we could do this? So in that way, you give them some control over it, but not the decision to tell or not. Okay, we can talk about that during this discussion. Oops, sorry.
Hey, Nick.
Okay, I want to show you what a brief suicide safety assessment looks like with someone who is acute positive. So this is a 17-year-old, and I'll tell you, this is actually based on a true story. That this was a 17-year-old, came in, mother thought he had mono. He was laying around all the time, and the nurse was not supposed to screen him because it was during their quality improvement project, it was just well visits, but she had a bad feeling about this. Her intuition told her to screen him. So she screened him, and this is how he looked. Yes, never tried it before. And then he was one of those very rare acute positives. So let's look at that.
Hey, Ryan. How are you doing?
Okay, how are you?
I'm all right. It's been a busy day. Hey, your mom called earlier and left me a message that she was worried about you and said that you've been really tired, and I think she even thought you might have mono. And so I'm glad that you came in. I know you were trying to go to school today, that you've missed some school because you haven't felt very good, she said. And, you know, my nurse said, gosh, Ryan just doesn't look like himself. And I think she had you fill out a couple forms. And we can certainly check a mono test, but there were some things that you answered, and I kind of need to ask you some questions about that. Would that be okay? Yeah. Boy, it sounds like things are not going too well right now. You're not feeling good. Is that right?
Yeah, I don't feel good at all.
Yeah. So it looks like on this one screen, it's a screen for depression, and boy, your numbers are pretty high. What's going on?
I got caught at a party the other night, drinking, and I'm supposed to go to college next year on a scholarship, and I think they might pull it. So I've been pretty upset about that recently.
Wow, I can see where that would be. That's a really big deal, isn't it?
I don't know. It just seems like my life's over now.
Did you talk to your folks about that?
A little bit. They're pretty upset with me. See if I made a stupid mistake or something.
Yeah. Sounds like to you this is a really big deal.
I'm really excited about college and graduating, but I don't know. It seems like that's going to happen anymore.
You said, I just heard you say, I feel like my life's over or might be over.
Yeah, I mean, if I don't go to college, like what am I going to do?
Right. Well, I noticed on this other questionnaire, you said you've been having some thoughts about killing yourself. Can you tell me about that?
Yeah, I mean, like I said, if I don't go to college, like what's the point? So I'd rather just be dead.
Yeah. Are you having those thoughts right now? No. Have you thought about how you might do that?
Yeah, my mom keeps a gun in their nightstand. I think I'd use that.
Yeah, and have you talked at all about any of these feelings with your mom or dad?
No, I don't think they get it. just really mad at me right now.
You're mad at me. Have you ever tried to kill yourself before? No. So I'm really concerned about what you just shared with me, and I'm so glad that you did. You know, you and I have known each other a long time, and I don't want anything bad to happen to you. Can you tell me a little bit about how likely are you to kill yourself with a gun?
Really likely. I mean, I think I could do it like, when my mom and grandma are out at church, everybody's out of the house. I'm not going to lock the gun so I could get it pretty easy.
Okay. You've been thinking about this a lot. It's really top of mind. Yeah, I'm sorry, that must be really scary. Yeah.
But, can't go to college.
Well, I can see that, it really feels like you feel hopeless maybe, and it sounds like some, just almost doesn't feel like there's any way out. And I'm really concerned because I want you to be safe, and I don't want you to die. And I think it's really important that we kind of try and get some more help for you. And what I'd really like to do is to call your mom and see if she could meet us here. And in the meantime, if it's okay, I thought maybe I'd just have somebody sit with you for a little bit. But I think it might be important for us for me to have someone who's really skilled at asking some questions, because I want to make sure that you're as safe as possible. So I'm going to need to call her, okay?
Yeah, that's okay.
Okay. Well, listen, I'm going to just have Sarah come and sit with you for a little bit right now, and then I'll give your mom a call, and we'll wait for her to come. And when she gets here, we'll just go over plans. Probably we'll need to send you to the emergency room today because they have staff that are really good about figuring out what's the best way to keep you safe. Okay. Thank you again for sharing this with me. I know this is probably really, really tough. And I'm worried about you.
Okay. So another very powerful and potentially a good intervention already, because he was able to voice it and she did a really good job of listening and being concerned with him and conveying that.
Hey, Ryan.
Oops, I'm sorry. Okay, so a lot of times pediatric healthcare providers are worried about screening because they don't have access. Maybe they don't have access to an emergency department. Maybe they don't have access to a mental health professional who can do the full mental health evaluation. So what are some brief interventions that you can do in your office that make a difference? So the first one is safety planning. We don't do safety contracts anymore. We do safety planning, right? So this is the Stanley Brown safety plan. It starts with warning signs. You help a patient develop and write down what triggers you, right? So some patients might say, every time my parents fight, I feel like killing myself. Every time my ex-boyfriend calls, I feel like killing myself. So you write those down. And then what are your coping strategies? And you see if you can elicit them from them. But if you can't, then it's writing in a journal, listening to music, playing music, doing exercise, watching a TV series, calling their best friend. What are they going to do? And then who are their social contacts? Who are their emergency contacts? What are they going to do if it's 2 o'clock in the morning and they have a thought about wanting to kill themselves? So you're preparing them for these future thoughts and you're putting actions on board. And then reducing access to lethal means. This is so important. Lethal means safety counseling is something you can do in your office with the patient and their parent. I know firearms is a really tricky issue, and it doesn't always have to be removed from the house. It could be safely store bullets and guns separate. and making sure they're locked up. Parents don't realize all the things they have in their medicine cabinets, like over-the-counter things like Tylenol and Advil, like all those can be used to kill themselves, for kids to kill themselves, and the parents not thinking about that. So when you have a kid at risk, or even when you don't, it's important to actually just not have those out and about. You know, your kids have friends that come over. Those kinds of things are helpful interventions. And then there's the resources you can provide, like the crisis text line, the suicide lifeline, there's a Trevor hotline, there's a trans lifeline, and now we have 988 that connects people with all these resources. So we have trainings, also further trainings available on the toolkit website. You know, we started with the Ask, through research in a few states. It's now being used across the country. We have some big data that I told you about last time, where a big hospital screened over 90,000 kids with the Ask. And so we know that the rates are high enough to warrant screening, but low enough not to overburden your practice. And then these are just some examples of places that are screening. Bright Futures in February has now come out with recommending suicide risk screening alongside depression screening. And they're not the same thing, right? Depression screening picks up depression. It is insufficient to pick up suicide risk. So it's important that you use two different tools for this. A lot of people, I'm just going to quickly go over this because this just came out this week, that the USPSTF came out with a very confusing statement saying that it didn't recommend either for or against. This is about having enough research to determine whether or not they were going to recommend suicide risk screening. The problem is that we have not done universal suicide risk screening for the past 60 years, and that did not reduce the suicide rate, right? So we know that. We know not screening doesn't work. So why not do screening? I think we don't have time to wait for 5 more years for more research to come out. We know that this screening is a really good way to ask questions. Okay. There is a blueprint for youth suicide prevention that the American Academy of Pediatrics and the American Foundation for Suicide Prevention, along with some collaborators from NIMH, created. It is a roadmap for how to embed suicide prevention in your practice. It's divided up into clinical section, community section, and then there's an advocacy policy section that NIMH was not a part of. But I encourage you all to go to aap.org/suicide prevention. And a lot of what, in fact, all of what I told you is in there, because the blueprint is based on those 3-tiered pathway that I showed you. So this is all a lot, but it's all very doable. And I want to end with a quote of, "Don't let perfect be the enemy of the good. There's an infinite distance between doing nothing and doing something, and a barely noticeable difference between doing something and doing something perfect. And so do something, because you might be the only person in that young person's life that asked them about suicide risk. And so you could really help save a life." So a lot of people went into creating these tools and this presentation, so I thank them. And now I'd love to open it up to questions.
Thank you so much, Dr. Horowitz. I will now dive into questions. Please feel free to type your question in the question box, and we'll cover as many as we can. Are you getting some feedback on my mic here?
A little bit.
Okay.
And not now.
Okay, let me see if I can read that. Okay. One of the questions that came in was about how often you should screen. So if a patient had a non-acute positive screen, how soon would you recommend they be screened again? And then do you start from the screening piece again and then move to the assessment again?
Yeah, so great question. So remember that screening is meant to detect, and then once you know something's on board, you do the assessment. So, but the ask especially wasn't meant to be given frequently. So there's no research that shows the right answer to this question. So what we recommend is no more than once a month, no less than once a year. So ideally, so that's for just routine screening. Then if a patient screens positive, then I would assess at, subsequent visits. So, last time you were here, you screened positive for, or you had some thoughts about suicide. How's that going for you now? And so then you can get into the assessment.
Okay, thank you. And a similar question is at what age can you start these screenings?
Great question. So we recommend universal screening. I will tell you that AAP recommends 12 and above. I'm going to recommend 10 and above for kids presenting with medical chief complaints, and then kids presenting with behavioral health chief complaints, 8 and above. We do have some studies with 8 and 9-year-olds. The preteens are the fastest growing risk group. They have less suicides, but they're the fastest growing risk group. So that's why, the AAP made Bright Futures said 12 and above to be in line with the depression screening, but it's really, I think, really good to start at age 10 if you can. It's not too young. You want to open up the conversation earlier, because early detection is your best shot at prevention.
Okay, thank you.
And can I just say one more thing? There will be kids under the age of 8 who have suicidal thoughts. We do not recommend universal screening for kids under 8 because, one, it's rare. It's very rare. It's out there, but it's rare. And so when something's so rare, you don't, from a public health perspective, we don't universal screen. There's also no screening tools. No matter what somebody says, there's no screening tools created for kids under the age of 8. So what's important is to recognize the warning signs. So if a parent comes in and says, my child always goes like this when they're mad, or they're talking about suicide, or the child's talking about suicide to you, then you have detected warning signs, and then you should assess. So we say assess rather than screen for the younger kids.
Okay, thank you. Any good tools, forms for stratifying risk factors? This in the context of potentially referring patient to higher level of care.
So there's, I wish there was a formula that we can say, hey, if this, then this, then this, and then you can refer to higher level care. It's gonna have to be your clinical intuition. Those 2 guides I showed you, like the Columbia, gives you risk stratifications, so of low, moderate, and high. The problem with that is the people on the low end of moderate and the high end of moderate are different people, but they get treated the same. And that's why we came up with the Ask Brief Suicide Safety Assessment. That's, I think, the tool that you need. And so as you're listening, you decide, because it all comes down to, is this person safe to send home, or do you need to send them to the emergency department? Are they safe to be alone? And so each case is very different, and you need to listen, and then you make your best estimate of what's the best care for them. And erring on the side of caution is important, but sending everybody who has thoughts of suicide to the emergency department is not a good idea, because there's cost to that too for the patient. And so you have to make a judgment call. How likely does it sound like they're gonna try to kill themselves? Can the parent keep them safe? Is the parent open to making sure the house is safe? Is the patient creating a safety plan with you? Are they taking your resources seriously? Can you hook them up with mental health services? So things like that help go into the determination, but unfortunately, There's not we have no tools right now that predict who's going to die by suicide. We just don't. So these are the best things that we can do.
Thank you, and I appreciate that question. That's a great question. Any comments on self-harm, cutting versus suicidal ideation, confidentiality, next steps, and how that differs from suicidal ideation?
These are really great questions. I was actually just presenting at the American Academy of Pediatrics conference, and that question came up. What do you do? So for confidentiality, if the patient's at risk for suicide, you have to share that with the parent because we're mandated to do that. Self-harm is different, right? So it depends what it is. If and only each case is going to be different. If it's self-harm that's non-suicidal self-injury, it is a risk factor for suicide, but it's not the same thing. And so there's, I think it depends what it is. If the child is cutting themselves, that's not covered under the same confidentiality legality. So, can you find a way with that patient to maybe bring in a parent if it's a parent they have a good relationship with? That's always really good. But sometimes, you're going to have to put that in the category as when they tell you they do drugs or they drink. Those are not things that pediatricians necessarily tell parents about. And so some self-harm falls under that category. I think it depends how serious it is and if you think it is suicidal behavior versus, a method of soothing themselves to feel better. It's tricky. It's really tricky, but it's not covered under the same confidentiality rule.
Okay, thank you. Are there additional trainings on how to become qualified to do the BSSA?
So, there are other trainings on how to do a suicide risk assessment. We have one on our website. It's pretty similar to what I just did with you. And sometimes you just have to dive in and do it. And there's a learning curve, of course, but the more you do it, the more comfortable you'll become doing it. And but it's really doing a suicide risk assessment. So there's a lot of webinars out there. There's some on the American Foundation for Suicide Prevention website, the NAMI website, the Zero Suicide website has some trainings and things like that. So there's definitely more training out there that you can do.
Wonderful, thank you. And maybe we'll try to squeeze in one more question. This is a great question. It's about how providers can address some of the disparities, because, I thought that was so important that you mentioned that there's different racial and ethnic disparities or disparities for those with different sexual identities. How can providers work to help address some of those?
Yeah. So it's really important, and it's an area of study now, and I know that NIMH is funding a lot of projects on underserved, understudied youth and minoritized youth. It's important to have culture. I just heard this term instead of cultural sensitivity, cultural responsiveness. And so, for example, the ask has a lot of words about killing and death. And when we have a partnership with the Indian Health Service, and we're rolling out suicide risk screening with the ask in their 20 emergency departments across the country. And there was a Navajo tribe that didn't want to use the word death because culturally that was, that brought death. And so we changed the wording of the ask. We're testing it now. But to make it more culturally responsive to, we are now tweaking it so that it fits in. So it's being responsive. It's trying to understand, like, for example, guns in the house. That's another cultural sensitivity, right? Some families have different values about having guns in the house, and it's important to respect that. But at the same time, half of our youth suicides are from guns. And 97% of people who tried to kill themselves with a gun succeed. So, or I shouldn't say succeed, die. I'm sorry, that's the language we're changing. But there's no opportunity for rescue when someone uses a gun. So it's important to have a culturally sensitive conversation with a family about what to do about these guns. It's not just, hey, get that gun out of the house. It's, how are we going to keep your child safe? We know that having access to a gun increases their risk for suicide. So culture can be, you know, all different things, but it's important to be responsive to the patients that you're seeing.
Thank you. And so we've reached our time, but I want to thank everyone for all the great questions that you've submitted. I'll end with a couple of housekeeping items before we close. The Carver College of Medicine has certified this course for AMA PRA Category 1 credit. So physicians may claim credit commensurate with the extent of their participation in the webinar. Iowa nurses may use certificates of participation towards their CE requirement for licensure. And certificates will be available to all participants who attended the webinar and complete a post-conference evaluation. So as I mentioned, the instructions for how to claim credit is in the handout section. I'll also send this in the follow-up email. And if you have any questions, please don't hesitate to contact me. I will send my email in the chat box. And in closing, I just want to thank Dr. Horowitz for taking the time to really walk us through these tools. I think it's so important, and I think it's that walkthrough really will help if people want to implement these in their clinic setting. So thank you so much for taking the time to do that. Thank you all for the questions and the discussion, and for joining today. And have a great afternoon.
Thank you so much. It was a pleasure.
Thank you.